Nat and myself will be co-facilitating today's session. Agnes, if you wouldn't mind going to the next slide. We just wanted to take a pause and acknowledge that although we are meeting virtually, we acknowledge that Baycrest and our related TC-Lin behavior support programs operates on traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit and Métis people, and is subject to the dish with one spoon, wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. Rounds is supported in part with funding from the government of Ontario, partnering with Behavior Supports for Seniors program, Toronto Central Lin, and the views that we are expressing here don't necessarily reflect the views of the province. I'd like to move on to a few housekeeping pieces. If you could just please keep your microphone on mute while the speaker is presenting. The session is being recorded and will be archived on the Ontario CLRI website as well as the Behavior Supports Ontario website. We will have 40 minutes of presentation followed by 15 minutes of discussion and wrap up. So any questions you have, you could just place that either in the Q&A or the chat and we'll be monitoring those. And if you have any technical assistance needs, Baycrest Telehealth is the person to direct those needs to. I'm going to turn it over to Anat.
Thank you so much, Stacey. I would say that today's topic, when I was reflecting on it, I would say that as a behavior support community, we do understand very well the value of understanding the person's past in order to effectively care for them in the present. Last month, to those of you that have been with us in rounds last month, we have discussed trauma-informed care in the context of the indigenous communities. And this month, I feel we are continuing on that path on trauma-informed care, but focusing on the topic of understanding and identifying post-traumatic disorder and dementia in veterans. I think it is not a coincidence that we have timed this presentation this month towards the upcoming Memorial Day, that no doubt is probably a trigger to many of these painful memories and experiences among veterans. So to guide us through this important topic, our presenter today is Dr. Kim Ritchie, who is a research associate in Trauma and Recovery Lab at McMaster University. She has worked as a registered nurse for over 20 years in direct care and clinical leadership roles, primarily focusing on mental health and geriatric mental health. She completed Ph.D. in rehabilitation science from Queen's University, conducting research on post-traumatic disorder and trauma and moral injury in military and veterans, healthcare providers, and public safety personnel. And I think that when we talk about healthcare providers, it becomes a little bit more relevant for us if we reflect back on the pandemic that we have gone through and still going through. And she's also a part of a part-time instructor for the nursing science program at Trent and Fleming School of Nursing. So lots of breadth of knowledge and expertise. Thank you so much for being with us today, Kim, and the floor is yours.
Great. Thank you so much for inviting me here today. I'll just see if I can get my screen share up. Okay, is that working?
It's taking a
Not yet,
minute.
but it looks like it's coming.
Yeah, it looks like
There we
it's
go.
just thinking. There we go. Thank you.
Great, thank you. Okay, so my name's Kim Ritchie, and it's really my pleasure to be with you here today. And I want to thank Enid and Stacy for the introduction and inviting me to present at these rounds. Today, I'll be talking about a research study that I did on PTSD and dementia in long-term care. And I don't have any disclosures, nor any commercial supports, and no potential biases to mitigate. So the objectives for today are first to describe how co-occurring PTSD symptoms of dementia are understood in veterans living in long-term care, and how PTSD symptoms can contribute to care challenges, and finally to consider the care implications of PTSD symptoms in dementia in veterans. So many people ask me how I became interested in this topic, and it really arose out of my clinical experience when I was working as a nurse in geriatric mental health and providing consultation to mental health consultation to long-term care. And probably over 10 years ago, and of course, this is a time where we knew much less about PTSD too. In one summer, I received referrals from 3 different long-term care facilities within this very short 2-week time span. And each referral was for a resident that had a fairly significant incident in the home. And all 3 of these residents had a history of care challenges, but none had had the significant incidents involving aggression before. I learned through the course of my assessment that all 3 of these residents were World War II veterans. And it was really something I found incidentally, and it was not known by the healthcare providers in the long-term care facility that they were veterans. So I completed my assessment, and after thinking about it a little bit, 2 points really stood out for me. And the first was, how is it that the long-term care providers didn't know that these were all veterans when that's a very significant piece of information to inform them? And then secondly, why were these very similar sudden behavior change within such a short time frame happened? So after this, I was driving and listening to a commentary on the radio, and it was a CBC report about a recent D-Day anniversary. And so that's June 6th. And it occurred to me after thinking about it that all 3 of these incidents took place in the weeks that were leading up to D-Day. And I began to think about that a little bit and about how, you know, simple things like having the TV on and having D-Day anniversary and memorial type things being broadcast on the TV might have triggered or inadvertently triggered these reactions in the veterans. So after this situation, I began to think a lot more about this intersection between past trauma and dementia, and began to ask more questions in my own work about a history of trauma. And over time, it really became apparent to me that there's differences in how individuals who had experienced past trauma tend to experience dementia. And I especially saw this in veterans and other high-risk populations for trauma. And then after that, I learned about some of the changes in long-term care for older veterans. And I'll talk a bit more about this later in the presentation. But these changes will mean that there's more veterans in community long-term care facilities as opposed to the more traditional or long-standing veteran long-term care facilities. And I started to think that, you know, if there's going to be greater numbers of veterans that are living in these community long-term care facilities, I thought it was important to know more about how to provide care for this population. So just to provide a little bit of background context, I'll start by discussing some of the literature on PTSD and veterans. and then PTSD in older veterans, and then look at some of the literature around PTSD and dementia. So as you're probably aware, the prevalence of PTSD is higher in the veteran population than in the general population. In Canada, the estimated prevalence of PTSD is 13% among veterans who served in the Canadian Armed Forces. This is compared to 2.4% in the general Canadian population. And similarly, in the US, the prevalence of PTSD is estimated to be 13.5% among veterans of Operation Enduring Freedom and Operation Iraqi Freedom, compared to 3.1% in the US general population. And also, as you're probably aware, PTSD is not unique to military or veteran populations and can occur in many other, for many other types of traumatic experiences, including interpersonal violence, motor vehicle accidents, also occupational exposures, as was mentioned in the introduction. First responders are one population, and more recently, healthcare providers from the pandemic. But there's a few studies to suggest that military and veterans may have more severe PTSD. And the first study compared military veterans and civilian crime victims diagnosed with PTSD to determine differences in their self-reported symptoms. And what they found was that veterans had more severe symptoms and greater levels of distress and impairment than civilians. The second study cited there compared 4 different types of trauma experience: battle or combat in veterans, civilian terrorism, work-related accidents, and traffic accidents. And they found that on all measures of PTSD severity, the veterans scored higher, indicating they were more severely affected by PTSD than from the victims of these other types of trauma. And also, military-related PTSD can result from many different types of operational experiences. First, as more commonly known, deployment and being involved in combat does have an increased likelihood of developing PTSD due to the exposures to trauma during these types of combat operations. But not all military trauma is deployment related. There are other types of non-deployment stressors, including some of the training exercises that are conducted, that can be conducted under extreme conditions, sometimes with dangerous machinery or live ammunition, that is designed to prepare military members for combat operations. And these carry with them also a risk of PTSD. Military sexual trauma also, which affects both men and women, is associated with an increased risk of PTSD. And this is especially relevant when we think about older veterans, because we often assume that if they were not deployed, then they are unlikely to have PTSD from their military world. But PTSD can result from both deployment and non-deployment related traumas. So before we talk about PTSD in older veterans, I wanted to back up a little bit and provide some context around how an understanding of the chronicity of PTSD has evolved over time. And PTSD was originally thought to be a self-limiting disorder that would resolve with rest. And the terms that were previously used to describe what we now think of as PTSD really reflect this understanding. So combat fatigue and battle exhaustion were terms that were commonly used during World War II. And this quote captures that line of thinking. Soldiers were giving sedatives to knock them out and enable them to sleep. They were given good food, a wash, and reassurance. They were described as being exhausted. And at the time, it was thought that rest away from combat would resolve these symptoms with time. And PTSD was not thought to be a chronic disorder that would impact older veterans. Another issue that also impacts the knowledge we have about PTSD in older veterans is the veterans themselves didn't talk about it. When they returned home from World War I or World War II, they tended not to discuss any of the symptoms or mental health issues that they might have experienced. And this will come up again later in the presentation when I discuss some of the research findings. So while we now know that PTSD can persist into many years after military service and into older adulthood, we really don't have a lot of information about PTSD in older adults. Most of the data we do have is from the US. And in terms of prevalence, Williamson did a systematic review of mental health disorders among older veterans and found a pooled prevalence of PTSD at 8.4% in older US veterans. And they compared that to other studies which found between 2 and 10% in community geriatric samples. And the range is due to the different studies that they looked at. In another study of US veterans living in long-term care, 9.4 met full PTSD diagnostic threshold and 15.6 met partial PTSD criteria. And by partial PTSD, what they meant is they met some of the criteria for PTSD, but not all of it. And there's only one Canadian study, and this was for Canadian World War II veterans living in long-term care, and 23% met the diagnostic criteria for lifetime PTSD, and more importantly, 16% for current PTSD. And one important aspect of when we're looking at military-related PTSD in older veterans is to think about the longitudinal course or trajectory, since the traumatic episode of military trauma may have occurred years or even decades earlier. And the first study to look at this was McLeod in 1994, who suggested that after returning from the war, the veterans experienced this initial period of time of high symptom experience, followed by several years of this mass period, during which time there was really no outward, or the symptoms were much less or not as apparent. But also during this mass time, it was a time when the veterans were busy with their careers and raising their families. And then as they entered into older adulthood, there was this reemergence of PTSD symptoms. And since then, there's been a little bit more information generated, and it suggests that it may not just be one simple trajectory, but there could be different trajectories based on the type of trauma or the severity of the trauma experience. And Hiskey in 2008 proposed 3 trajectories based on his review of trauma literature. And the first one, he suggested that after the initial trauma episode, there was this acute PTSD time, and then the symptoms became chronic and stayed chronic into older adulthood. And in the second one, he suggested the symptoms emerge between 5 and 35 years after the traumatizing event, and then again remain chronic into older adulthood. And then the third trajectory is similar to the first one by McLeod, where there's this mixed presentation of symptoms that begin within 5 years after the traumatic episode. And then there's this symptom-free period that can last anywhere between 15 and 30 years, followed by this PTSD exacerbation or symptom exacerbation in older adulthood. So that brings us to PTSD in older veterans. And as we saw on the slide before, there seems to be this worsening of symptoms in some veterans as they enter into older adulthood. Often anniversaries can be a trigger for some veteran. And one study suggested that during the Persian Gulf War, Veterans Mental Health Clinic in the US received 3 times the number of calls for mental health services, mostly from World War II veterans. And it's unknown why these symptoms reemerge in older adulthood, but it's been suggested that the presence of a stressor such as physical illness, psychosocial stress, and cognitive impairment, which is important for this study that I'm going to be sharing with you today, or retirement, can be associated with the emergence of PTSD in older adulthood. So now looking at PTSD and dementia, there's some research that suggests that PTSD and dementia have this bidirectional relationship. And so the first part of that relationship is that PTSD is associated with an increased risk of developing dementia. And there's two studies I've cited here, and these were really the first ones to really talk about this relationship. And they're both US, and they're both done with fairly large numbers of US veterans. And what they found was there was about a 2 times higher risk of developing dementia in veterans who had PTSD compared to veterans who didn't have PTSD. And these similar studies have been done since 2010, and they all seem to suggest somewhere in this likelihood of 2 times higher risk, even accounting for some confounding illnesses such as traumatic brain injury. So now turning to the other part of this bidirectional relationship, and this is the focus of the research that we're going to talk about, where with the onset of dementia, the veterans can experience either an emergence for the first time, a reemergence, or a worsening of PTSD symptoms. And again, there's very little information about this. And what information there is mostly in a few case reports. And I've listed some of those case reports there, which really talk about this range of symptoms, such as increased suspiciousness, physiological hyperactivity, verbal aggression, physical aggression, re-experiencing such things as war-related nightmare or war-related flashbacks or nightmares. And the mechanisms that underlie this reemergence or emergence in older adults with dementia is really unknown. But it has been suggested that individuals with dementia may be less capable of using coping strategies. So maybe avoidance was used as a coping strategy in adulthood, and then with dementia, it became more difficult to use that type of coping strategy. And this would be especially apparent in long-term care, where there could be many triggers present, such as television or other types of reminders of the military. And these can no longer be avoided and could cause can remind the veterans of these previous experiences, causing a reactivation of distress that was associated with the original trauma. And since this study focused on long-term care, I wanted to briefly review a little bit about what long-term care for veterans in Canada looks like. And as probably many people on this call are aware, is that the veterans' long-term care facilities really came from these agreements made between the federal and provincial government many years ago. And they designated contract beds or priority access beds in these long-term care facilities for the exclusive use of qualified veterans. Many of them are located in formal federal veteran hospitals facilities where entire wings are dedicated to the long-term care of veterans. And some have enhanced programming funded through Veterans Affairs Canada, such as woodworking or music therapy. And they tend to incorporate this veteran-centric approach where they may have a lot of military pictures or ceremonies and remembrances and memorials. And in Ontario, we tend to think of Sunnybrook and Pearly Rideau and Parkwood, although there's others across Canada. In addition to these larger facilities, there's also a smaller number of contract beds and about 200 provincially licensed long-term care facilities located all across Canada. So currently, long-term care for veterans is in a bit of a transition. So according to the federal legislation, these contract beds are restricted to war service veterans. And so war service veterans are those who served prior to 1954 in the First World War, the Second World War, or the Korean War. And all other veterans who have served since 1954, so this would be including our Canadian Armed Forces veterans, don't have access to these contract beds. And instead, they access community beds, the same as any other Canadian in a provincially funded long-term care facility. So just looking a little bit more at the impact of this change of legislation. As of 2019, there was an estimated 640,000 veterans in Canada. Approximately 40,000 were war service veterans. Whoops, sorry about that. 40,000 were war service veterans with an average age of 93 years. The remaining 600,000 are Canadian Armed Forces veterans who served since the Korean War, and they have an average age of 58 years. So what this means is that there's this real growing number of veterans in Canada who in the next decade or so will be entering into an older adulthood. And we may start to see an increase in the number of these veterans who will need long-term care services of these 600,000. And to meet this growing need of aging Canadian Armed Forces veterans and knowing they can't access the traditional contract beds, Preferred Admission Initiative was developed by Veterans Affairs Canada to reprofile some of the contract beds. As of 2018, 10 of the former veterans long-term care facilities had signed short-term reprofiling agreements for a total of 132 beds that were designated for the use of Canadian Armed Forces veterans. And these agreements are not permanent. They were designed as an interim measure while Veterans Affairs conducts a program review. And one of the current issues is that the demand for these beds currently outweighs their availability. And there's a wait in some cases of over 2.5 years or more for access to these beds. And this number is especially concerning considering, as we said, there's going to be a growing number of aging veterans in the coming years. And there's also some provinces in Canada who don't have any of these agreements established, and they don't have any of these reprofiled beds available for Canadian Armed Forces veterans. So overall, there's uncertainty right now in the future of long-term care for veterans. So it's unknown if this preferred admission beds initiative will continue and how many beds will be allotted. And given the changing demographics in aging veterans, more Canadian Armed Forces veterans will likely live in community long-term care beds instead of the veteran long-term care facilities. And so one of the concerns in the literature is that the loss of these veterans long-term care homes could also result in a loss of the healthcare provider experience and expertise in veterans' health issues. So in summary, given the lack of information in literature, there's a need to improve our knowledge about PTSD and dementia and veterans living in long-term care. So since this is a very new area of research, we decided to take a very exploratory approach, and we conducted 3 studies. First, we looked at a scoping review on the relationship between PTSD and dementia in veterans, and found there was this lack of information about the symptom expression of PTSD and dementia and how it impacts care. We then did a multiple case study, and we looked at how PTSD and dementia is understood in veterans living in long-term care. And then a third study focused on how healthcare providers in Canada have been able to learn to identify PTSD and dementia in veterans. Today, for this presentation, I'll focus mostly on the multiple case study, and I'll point out a few areas where there's overlap with the findings of the third study. So just to tell you a little bit how we went about the study, our inclusion criteria for the multiple case study was that each case must include a war service veteran diagnosed with dementia. And for PTSD, it was a little more difficult since there was no diagnostic criteria for PTSD with dementia. So we developed a study definition that was derived from the literature. And then each of the veterans had to live in one of these formal federally funded long-term care facilities. And the reason for this was that these facilities had the majority of contract beds, and they also were similar in terms of their programming, and the healthcare providers would have similar knowledge of veteran-related healthcare needs and mental health. And then for each of the cases, we collected data from the veterans themselves, their caregivers, and 3 of their healthcare providers. So for our data collection, interviews were conducted with the veterans, their caregivers, and their healthcare providers. And their healthcare providers were 3 of the actual providers that provided the most direct care with them. We also did a period of observation in the long-term care facility, where we would observe the veteran really interacting within their environment, going out for activities, interacting with other residents and with the healthcare providers. We also did a chart audit that consisted of the past 6 months of progress notes and also the care plan. In total, we conducted 19 interviews, 4 veterans, 4 caregivers, and 11 healthcare providers. And for each case, we also collected data from the observation period and from the chart audit. The veterans, they all ranged in age from 90 to 96 years and had lived in the long-term care for 1 to 3 years. They all had a confirmed diagnosis of dementia, either non-specified or Alzheimer's. 2 veterans also had a diagnosis of PTSD that was made following the onset of dementia. 2 had a prior history of diagnosed depression, and 3 of prior alcohol dependence. And all the veterans were Caucasian and male. Their military service varied. 2 served in the Canadian Army, 1 in the Royal Canadian Navy, and 1 in the Royal Canadian Air Force. All the veterans had been deployed, 2 during World War II and 2 during Korea. The caregivers were all either the son or daughter of the veteran, and the healthcare providers consisted of personal support workers, registered practical nurses, registered nurses, and the physicians. So for our findings, 3 themes emerged from our analysis of the data. I'll go through each briefly, and I'll use a participant quote to illustrate that theme. The first theme we call same but different, and this was meant to describe that when we initially asked about the symptom expression of veterans with PTSD and dementia, they were described as very similar to that of veterans who had dementia only or were not thought to have PTSD. So they were described as having symptoms such as suspiciousness, agitation, fear, etc. But at the same time, the participants said that their symptom expression was completely different. And when we looked at this, it was more of a nuance, and it was in the intensity of the symptom expression that was described as different. And this increased intensity was described in 2 ways. First, the actual symptoms themselves were described as more severe or exaggerated or amplified. For example, one of the veterans, they said that he would barricade the door to his room with all of his furniture every now and then because he thought others were trying to steal his belongings. Another veteran was described as having this more intense expression of sadness. And he would have these crying spells throughout the day. And this was interesting because they felt that this was not depression because he had no other symptoms of depression and it didn't improve with antidepressants. But they thought it was related directly to his past military trauma. The second way intensity was described was that these symptoms were always present and underlying. So this was described as different than the veterans who had dementia only, where they said that their fear or suspiciousness was more intermittent through the day, and it was in response to certain triggers that were known. In veterans with PTSD and dementia, they felt that this fear or suspiciousness was always there and underlying actually every care interaction. And in turn, what had happened was it created this heightened sense of awareness in their environment. One nurse commented that the veteran was always on edge and really had this lack of peace. And I thought that really sort of defined what they were trying to say, is that there was this sense of always having this intense underlying fear. And participants in the study reported that being able to identify or being able to see these differences between PTSD and dementia really required two things. And one was knowledge that there was past trauma and past military trauma. And the second thing was that the healthcare provider was aware that PTSD could co-occur with dementia. So for the first part, the knowledge of past trauma was really interesting because the healthcare providers in the study said that how they usually tried to identify if it was PTSD was that they gathered data or they gathered information from the family about a history of trauma. And they found that even if the family said that they didn't think their veteran father had experienced any trauma during their time in the military, that they needed to be mindful that sometimes they may just not know. And going back to one of the initial slides about the veterans didn't talk about it, and that's what they said happened, is that oftentimes the veterans didn't talk about any military trauma and the families didn't even know about it. And so they said they always had to keep that question in their mind that maybe there actually was trauma and the family didn't know. And when I spoke with the family caregivers in this study, they said pretty much the same thing. They said their father didn't talk much about their military experiences, or if they did talk about it, it was all about the positive experiences of being with their comrades and about the bonds that they shared. But they didn't talk about any negative experiences. And they said they didn't know about any trauma in a lot of cases. And similarly, when I talked to the veterans, they were all very expressive during the interview. But as soon as I asked about their time in the military and specifically about any negative memories during their time in the memories, all four of the veterans immediately changed the subject and wouldn't talk about it. And they all pretty much verbatim said, we don't talk about that. And we left it there. About the second part about recognizing PTSD and dementia, a lot of the healthcare providers in the study said that they felt that there was really little known about PTSD and that many healthcare providers are not aware that it can co-occur with dementia and tend to only think about dementia or even delirium or depression, and that this was a barrier to being able to identify it. The next theme was around the differences in the complexity of care. And overall, the participants reported that all aspects of care required more time and emotional effort from both the family caregivers and from the healthcare providers. In some of the cases in the study, the veterans were described as the most challenging on the unit. And they said the challenges came from this amplification or exaggeration of their emotional responses to everyday events like care or mealtime or other types of activities. So for example, they said that during care, the veterans were more likely to become agitated or suspicious. And they realized that these reactions really stem from this heightened level of fear that was always present and underlying. So what they did to reduce fear is they wanted to give more time for care compared to other residents. And they found that spending this extra time seemed to avoid this escalation in agitation or aggression. So the challenge of care actually came from the fact that they didn't have the time or the flexibility in their work schedule to allocate this time. So instead, they developed these workaround strategies like caring for all the other residents on the unit and leaving these veterans until last, so that they would try to keep a little extra time and wouldn't be pressed to get to the next resident. One of the really interesting findings I thought in this study was that that the veterans with PTSD and dementia were described as having different responses to usual care strategies. And the biggest example of this was around redirection. And they said it's either completely ineffective or actually exacerbated the situation. Whoops, sorry, again. There we go. So what happened is that when they tried to redirect the veteran and tried to distract them to go to another activity, they said it actually increased agitation and they couldn't redirect the veteran at all. And this was an area of overlap with a third study where the healthcare providers in that study also reported that redirection was ineffective or could actually worsen things with veterans with PTSD. And it was really interesting because when I asked the healthcare providers why they felt redirection was so ineffective, they thought it was because in moments of this really increased agitation, that they could be re-experiencing past trauma memories. And in that moment, they just couldn't be redirected away from that. And that by trying to, it actually increased their agitation and sometimes their suspiciousness as well. And this lack, and the challenge in this really came from the lack of effectiveness in redirection, because there was few alternate strategies that were found to be effective. In most situations, the healthcare providers said they either left and came back later. And the third theme from our results really focused on the care strategies that were found to be more effective. And overall, these care strategies were similar to those you'd find in a lot of the different types of person-centered care interventions. But the difference is that there was this added dimension or added layer that really distinguished it, that they had to go beyond, above and beyond what these usual care strategies were. And overall, the most effective strategy really can stem from the fact that the interventions had to be designed to help the veteran feel safe. And building trust, which of course is central to all care, was described as the most important, but it kind of went above and beyond because it took on the level of an explicit intervention. And the intervention was designed to address this underlying sense of fear and vulnerability. So, for example, they went to extra effort to slow down, to establish a connection, and before any care interaction at all, above and beyond what they would do for other residents. And they found that by doing this, it really seemed to help to build up some trust and to also reduce the levels of fear in the veteran. Another example highlighted in the quote here was really being attuned to the veteran's moods and recognizing when he needed to talk about his military experiences. And they found that not taking the time really caused symptoms to escalate, resulting in the more time to de-escalate later in the day. And another interesting thing about this part was that although these strategies were really suggested to be essential, they weren't really well reflected in the documentation. And what was happening is these extra steps were being passed verbally, and they were known amongst all the regular staff. But the problem came, of course, when there was new staff or staff who were unfamiliar and they weren't aware of these extra steps. Another care approach was described as going into their world or going with him. And this was an approach that was used as an alternative to redirection in these moments of increased agitation or suspiciousness. And what they did is they said they entered into the veteran's world, and instead of trying to redirect them, they would offer reassurance and validation. So they would say things like, "We're safe, you're safe right here," or "I'm safe," or I'm safe, you're safe, and I am with you, and I'm going to be here, and I'm going to help you. And they found that this approach was much more effective at reducing these moments of high agitation. And the last care strategy was really about making a more intentional effort to ensure consistency and routine among care providers. And they found that even just very small changes in daily routine caused this increase in suspicion and sometimes aggression above and beyond other veterans with dementia. One way they tried to keep consistency was having the same staff, which of course is common for many people because they felt this would help to build trust and continuity. But this wasn't true all the time. So for example, 3 out of the 4 veterans in this study had a paid companion several times a week to help manage any behavioral challenges and to provide this additional one-to-one time. In 2 of the cases, having this consistent person actually resulted in increased suspicion. And the healthcare providers in the study said that they see this quite often, and they felt it happen more often in veterans with PTSD and dementia. So in summary, we found that identifying PTSD and dementia is really challenging, and much more research needs to be done in this area with larger and more diverse samples to really understand and characterize what PTSD and dementia looks like. But our study results also suggest that it's important to be aware of the possibility of PTSD and dementia. And that's an important part also of recognizing these differences. And this is especially relevant when working with these higher risk populations like veterans and first responders. Also, observing for these increased intensity or unusual responses to interventions may serve as a cue that there may be something else going on, and maybe there's a trauma history. Also observing for triggers in the long-term care environment, and being mindful that the triggers may be different for those who have a trauma history, and that the long-term care environment itself can be re-traumatizing for some individuals, either due to just being in an institutional environment. And this has been found actually in prisoners of war, where there could be re-traumatizing just being in that institutionalized environment with power imbalances. And also for veterans, triggers can be hearing different languages in long-term care environments, also having the television or other types of cues of military, or even hearing other residents asking for help or needing help. And another point is that our study results suggest that when caring for veterans with PTSD and dementia, the interventions really need to be tailored to really look at these specific symptoms such as fear in order to and to build trust. And of course, operationalizing these strategies into care plans helps to provide the consistency to reinforce this. And the last point is really about education, and the healthcare providers and the care providers in this study really talked about the need to increase awareness and knowledge about PTSD and dementia. And education is available currently on PTSD in older adults, but there's really very little out there about PTSD and dementia. I found one module that was put out by Veterans Affairs in the US on PTSD and dementia, but that I haven't found myself much more than that, but maybe others have. I think another point is that we need to include this information in educational resources and clinical guidelines, because there seems to be a gap. And so educational resources for dementia care often don't include information on PTSD, and those for PTSD often don't include information on dementia. A recent example is that Veterans Affairs Canada developed a resource guide on dementia. And although they recommend consideration of different comorbidities, the only depression and anxiety were mentioned. Also, there was a booklet put out by the National Center for PTSD in the US, and it was titled Understanding PTSD and Aging, but it didn't mention PTSD and dementia. And then lastly, just that with the changing in demographics that we mentioned before, there's really this time now to start looking at implementing some of this training and starting to increase our knowledge base to start developing our knowledge to care for older veterans in our future years. And I'd like to acknowledge the support of the co-investigators on this project, Heidi Cram, Alice Aiken, Catherine Donnelly, and Catherine Goldie. And thank you so much for your time.
Thank you so much, Kim. This was such a fascinating presentation, and I would invite people to either unmute yourselves to ask your questions. You could also raise your hands by using the raise hand button, or posting your questions on the chat if you're more of a shy person. And definitely, Stacy, thanks for posting the links to where you could find the recording if you wanted to go back or share the recording with colleagues. It's certainly, I think, a fascinating, integration that you've done between the dementia and post-traumatic syndrome. It took me back down memory lane when I was working in long-term care home as an occupational therapist. And I remember one of the residents kind of grabbing me by the hand and saying, "Get me out of here, they're out to get me." And I knew that this was activated from a post-trauma of them living through the Holocaust. And but it always grabs my attention, how subtle the triggers can be. Language, just hearing the language of where you fought or where you had the conflict with, and things like that. Just like in the previous rounds, we've heard that the word drink or resident could be a trigger because of residential schools or because of alcohol abuse. So it's very, very, very interesting and kind of insightful to think through this. I'm wondering if there is any question, or if people participating can share with us impressions of or things that they've been seeing on the ground in their clinical work in relations to this topic.
Aina, there's a question from Joyce McDonald. Joyce says, "What a great presentation. I volunteer with TMFRC and love this topic. I was curious whether the studies were done on both males and females. Also wanted to know about the contract beds and if these are both male and or female."
Yeah, thank you so much for the question. And for this particular study, we only had, it wasn't intentional, but there was only male veterans that were included. But I completely agree that, I think there has to be a lot more research done, including, more diversity with female veterans, and also, different types of ethnic backgrounds is really important to think about too. There's one study that I'm aware of that's specifically on female veterans that looks at PTSD, not necessarily with dementia, and also found fairly elevated rates compared to the regular general population, but that's the only one I'm aware of.
Marilyn is asking, is there a breakdown of the veterans' experience in a theatre of war? That is, are there differences in those older or younger veterans with PTSD?
Difference in PTSD severity?
Marilyn, would you be able to clarify?
We'll also note that our poll questions are there on the screen for people to respond to. We would, Kim and us will appreciate your feedback.
While we wait for Marilyn to type, Mary has commented, in long-term care, I find that we do not have enough information about a veteran client, only to say that they were.
That they were, I guess, veterans.
Yeah,
Okay.
that was what, sorry, go ahead. I was just going to say, I would love to hear from some people on the call too about that, because that was a question that I had on how are veterans being identified in community long-term care now. And because it was actually a bit unclear to me when I was trying to find out myself, other than the small little tick boxes, that all the information that's currently given, when, so much more would be richer information to inform what types of care strategies you might want to implement, and if there had been any sort of military trauma.
So Marilyn is identifying a difference from those from the Iraq War, World Wars, or Vietnam vets. Are there differences with PTSD?
Yeah, just thinking, I'm not quite sure myself. I would need to look into that. That's a great question, because it will inform sort of future, and I'm not quite certain of the answer, but I could find it out and get back to you if you'd like.
We do have one question for someone that raised their hand. Olga, if you want to go ahead and unmute.
It's Olga from Baker's Behavioral Support Outreach Team. I don't know, guys, if you can see me. It's a little bit different from regular Zoom. It's not a question. I just want to say that in Baker's we have a big community of Jewish residents who went through Holocaust, and they have a lot of behavior associated with being in concentration camps, and a lot of triggers, we can see that affect their behavior. I mean, it's also PTSD, right? Just want to comment that it's very useful for us. Thank you.
Yeah, thank you, Olga. I think, I really feel that a lot of the work that has been done already at Baycrest, and, Paula Davis' work that she did, Paula Davis' work that she did a while ago, can really start to inform what we should do, because a lot of education has been done. A lot of really amazing programs have been developed. And so I think similarly with veterans, we're just starting to learn more and more about veterans and trauma and PTSD and dementia. And I think that that serves as a wonderful foundation to start building our knowledge base on, and similar types of resources, and what those triggers might look like. Maybe they're different for veterans than they are for Holocaust or other types of trauma survivors. But right now, we just don't have that knowledge. And I think we've got a great opportunity now to learn and to develop some of this.
Well, thank you
And
so
also,
much, Dr. Ritchie.
I just wanted to highlight, Stacey, before we go, the comment from Elise, just suggesting sorry, not Elise, Jennifer, I think, just highlighting the All About Me book that we actually are using in BSO as a resource for transition. And it's a great comment because it is a great tool to collect that history and information as people transition into those environments. So I just wanted to highlight that.
Thank you.
Well, thank you, Dr. Ritchie, for sharing your insight and your experience today. Certainly a lot of comments and questions from the audience, and we really appreciate the time. So thank you everyone for joining us for rounds today. Ainat, any final words?
No, just thank you very much. It was fascinating.
Thank you.
Thank you.